So there's been a lot of progress in genetic testing for cancer. Many people have access now to superior technology, next generation sequencing that can look at multiple genes at the same time and can analyze a more complete array of mutations than the old technologies could offer. So it's easier and more accurate testing. It's also less expensive testing than was available before. Insurance usually covers testing in most countries, and there are laws now in many countries to help prevent discrimination based on genetic testing. All of these things make it more attractive for people to have genetic testing and to understand their risk. And for cancer patients who have genetic testing, much of the benefit for them can be for treatment, but also it's to answer that question every cancer patient has about whether their relatives are also at risk for the cancer that they're going through. So you can not tell them completely, but much more accurately than before. So the best example is still the BRCA1 and BRCA2 genes that were originally targeted in breast and ovarian cancer. And in ovarian cancer, they are predictors of response to a group of therapies called PARP inhibitors, and now to combination therapies with PARP inhibitors and to platinum drugs. The ovarians have been the most sensitive tumors, but we also have evidence in breast cancer in advanced disease, and in the plenary session at ASCO today, they'll be announcing the results of the POLO trial, which shows improved outcomes in patients with pancreatic cancer and BRCA1 and 2 mutations. And there are other data in prostate cancer. So all of the tumors that occur in people who have these mutations can be effectively treated. And that is a remarkable finding and has really motivated oncologists to think about genetic testing for inherited genes for their patients, in addition to analysis of the tumors themselves. And there are other examples too that may help guide immunotherapies, especially in colon cancers and related tumors. So we know a lot about a few of the most powerful genes, but we have a lot to learn about some of the more common but less powerful genes, and we need large groups of patients to study to understand how best to predict risk. Even in the patients with BRCA1 and 2 mutations and colon cancers, for example, where we know the genes, we're still not able to really precisely counsel each individual person about his or her specific risk. We only have general numbers. So we have a lot of work to do with that. And that will keep geneticists busy for some time. And we still need to understand the mechanisms of the susceptibility for some of these genes, which we hope will encourage more targeted therapies for individuals with those mutations that do not respond to the current PARP inhibitors or immune treatments.